All right, we'll go ahead and get started. Thanks everyone for coming to our neuro-oncology block. We've got some really great lectures today. Our first one is from Dr. Michele Miller. She is a neurosurgery resident at our Ochsner-Tulane Neurosurgery Residency, and she is going to be presenting on her research on minimally invasive resection with brachytherapy versus SRS for brain metastases.
So as Dr. Golden said, I'm Michele Miller. I'm a PGY4 in the Tulane Ochsner Neurosurgery program. This work was done with Dr. Ware as our PI, and Dr. Keene was also one of the surgeons instrumental to this, who's going to be talking today as well. I'd also like to give a big thank you to Smriti. This is really a lot of her first author work, but she is one of our medical students at her match day today for neurosurgery, which is very exciting. And Zainab is actually also at her match day, so congratulations to both of them. I'm going to talk first about our paper, which was published a few months ago now, but that was a prospective trial looking at minimally invasive craniotomies with cesium brachytherapy. And then to try to address one of the main limitations of the paper, we went back and retrospectively matched that group to a standard of care SRS cohort. And I'll talk a little bit about the oncologic outcomes there, as well as some cost analysis. So as everyone knows, metastatic brain tumors are very common. They affect up to 40% of cancer patients. For us as neurosurgeons, they're the most common tumor we see in adults. Standard of care for these, if they are large, which is typically defined as about 3 centimeters, does involve surgical resection followed by radiosurgery or whole brain radiotherapy. The goal at our institution is usually to get people in about 3 weeks post-op for their radiosurgery. Standard of care traditionally is kind of extended out to 6 weeks for that time window. And then, more and more these days, people are really pushing the number of metastases that are treated with radiosurgery as opposed to whole brain due to the cognitive side effects of whole brain. And then for larger resection cavities, hyperfractionation is important to reduce the radiation necrosis risk. So, what are the limitations of that? Why even think about brachytherapy? Well, the main thing is there is clearly, it's a second visit down the road. There's a delay in therapy during which other lesions can keep growing. Sometimes you can have early recurrence or progression, and then some patients are inevitably going to be, unfortunately, lost to follow-up within that time frame. So brachytherapy is direct implantation of radioactive isotopes into the resection cavity with the assistance of our radiation oncologists at the time of surgery. Historically, there were trials with iodine-125, I believe at UCSF. They had good local control, but very high rates of radiation necrosis. And that has therefore been largely abandoned. Cesium-131, however, has a much shorter half-life of 9.7 days. So that allows for quick delivery of the therapeutic dose, but lower rates of radiation necrosis. In our study, we did a planned dose of 80 gray to a 5 millimeter depth. And then in this figure here, you can see just a nice example case. So you can see this enhancing deep left frontal lesion that was resected using a minimally invasive approach, which I'll talk about a little more in a second. The CT scan there, you can see all the little beads with right after surgery that have been placed. We used, I think it was kind of some Surgicel as well as a glue sealant to try to keep those in place and not migrate. And then in C there, that's the initial post-op MRI showing a gross total resection. And in D, this patient had a really nice outcome where that was a 1-year post-op MRI with no local recurrence. So Dr. Keene is going to talk more about this, but briefly, what do I mean when I say minimally invasive? It's typically a small, 6 to 8 centimeter linear incision that we're making. The craniotomy, so the bone opening, is about 3 centimeters in diameter most times. And then for a deep lesion, like the one that we were just looking at in that picture, we insert a tubular retractor pictured there under neuronavigation. And then there's been a variety, and I'm sure Dr. Kuhn will talk about this more, of potential benefits of these approaches versus traditional larger open approaches, but there's reduced parenchymal trauma, potentially few neurologic complications. Some series have shown faster recovery, less pain meds, or improved wound healing. So the idea for our study was just really to combine those two things. As a single center prospective trial at Ochsner from 2019 to 2021. It was sponsored by IsoRay, which was the company that makes the cesium beads. It included 21 adults with 1 to 6 newly diagnosed brain mets that required surgery. The decision of surgery was made independently of enrollment in this. They had to have a KPS of at least 60. Patients with prior radiation were excluded. Patients with life expectancy less than 3 months were excluded, but that's kind of a general criteria for us anyways when we're selecting patients as surgical candidates. It's not necessarily unique to this study. Primary outcome was freedom from local progression. Secondary outcomes were quality of life and other functional outcomes, the dosimetry, and complications, notably including radiation necrosis. And there were also Kaplan-Meier analyses for survival and distal recurrence. Looking at this in kind of a timeline format, so you had your patient with a new brain met diagnosis, and they underwent the craniotomy with placement of the cesium beads, again, goal of 80 gray to 5 millimeter depth. They had both a CT and MRI within 48 hours to assess the resection and calculate the dosimetry. And then follow-up was a 2-week post-op follow-up, and then every 2 months for a year or for however long the patient survived. And at each follow-up, they were given a KPS score, ECOG score, a FACT-BR questionnaire, which is a quality of life, well-validated in an oncologic setting, questionnaire, mini mental status exam, and a contrasted MRI. So what did we find? First of all, there were very good rates of gross total resection. 20 out of 21 patients had gross total resection. The one patient that had a subtotal resection had a local recurrence. There were no other cases of local recurrence, and that panned out to be a 92% 1-year local freedom from progression. So that part was great. There were no cases of radiation necrosis. That was also great. However, there was only a 5.9-month median overall survival, which is low. That we believe was significantly confounded by the fact that this was occurring right during the COVID pandemic, and there were 5 deaths clearly attributed to COVID, which we believe unfortunately negatively impacted that number. But that is one of the main limitations of this work. Here are Kaplan-Meier figures. You can see the 92% 1-year local freedom from progression. The distal recurrence, 4 patients had distal recurrence at a median of 143 days post-op with a 54% 1-year distal freedom from progression. And that's looking at appearance of new lesions within the brain, not, I think it's greater than 5 millimeters away from the resection cavity. And then the overall survival curve, again, we believe severely COVID impacted. Median volume of the tumors resected was 10.6 centimeters cubed. There was a significant Spearman correlation between the V200 coverage and survival time, but then looking at it with a different univariate analysis, it did not retain significant prediction of overall survival, but maybe some signal there. In terms of our functional outcomes, there was no significant differences in KPS, ECOG, or mini mental status at various time points. Just looking at it numerically, KPS went from 80 pre-op to 90 post-op, but that was not a statistically significant difference. The FACT-BR questionnaire did show some statistically significant improvements in specific symptoms, including seizure frequency and improved memory and thought organization. But there were mixed results looking at different kind of emotional domains and no significant changes in the social domains. So in summary, this was recently published last December in the Journal of NeuroOncology, but we had 21 patients treated with minimally invasive trainee plus brachytherapy seeds with high rates of local freedom from progression, no cases of radiation necrosis, but the two main limitations are poor COVID-impacted survival and the lack of a comparison arm. This was a single-arm study. So we thought, ideally, you would have matched this to a standard of care cohort. So we went back and tried to do that best we could retrospectively. So I'll talk about that for the remainder of this. We looked at our patients from 2019 to 2025 that had standard of care surgical resection plus radiosurgery. Of note, those cases were mostly what we would classify as open, so without the tubular retractors. And that time window is not exactly matched because basically in order to get the best matching for the histology and the age, we needed to expand the time window. But therefore, the impact of the pandemic is different across those two groups, so we didn't have survival as a primary outcome in this retrospective matched analysis. But we did match for histology pretty exactly, for age within 10 years, and then we tried the best we could with tumor volume as well, but you'll see there's some variability there. And we were trying to look at and compare the local recurrence between the groups, as well as the distal recurrence and rates of radiation necrosis. And then secondarily, we also did a cost analysis looking at quality adjusted life years in a couple ways, as well as doing an ICER analysis. So this is a list of the pairs of patients. The pathology there was matched exactly, except for one breast cancer patient having an ER mismatch. The ages are, like I said, tried to be within 10 years. The volumes, if you look individually, there are some pairs with some significant discrepancy, but if you look at the kind of overall numbers, medians and interquartile ranges, we felt like it was a reasonable comparison. Of note, there were two patients in the study, the original study, that just we could not find a good match for, so they were excluded from this retrospective comparison. But essentially what we found there is there were two cases of local recurrence in the radiosurgery group, none in this brachytherapy group. Again, going back to the original study, there was one case there, but basically there's no significant difference in local recurrence between the brachytherapy and standard of care. And there's maybe a trend towards improved distal recurrence in the so less distal recurrence in the brachytherapy group. Is not statistically significant, but you could potentially think that, maybe if these patients are getting treated up front, maybe they're able to resume systemic treatment earlier. That could be a potential explanation for why you might see that signal there. And then the cost effectiveness of this. So among 20 brachytherapy patients that we had data for, the median direct hospital cost is $14,000. And then the quality adjusted life year was 0.5, so it's $30,000 per quality adjusted life year. There was only data for 13 matched pairs available, so we looked at that between the radiosurgery and brachytherapy groups. And the brachytherapy group had significantly lower median costs, as well as hospital charges, with comparable quality-adjusted life years and net revenue. This is that's shown in a, ICER diagram. So the bottom right quadrant of that figure are the dominant pairs where it's both cost-effective and improved quality-adjusted life years. There's two, conversely, in the top left dominated pairs where it's not good. The top right, one patient was deemed cost-effective, and then there's four in the bottom left quadrant where it's kind of a trade-off where there was slightly lower quality adjusted life years, but also lower cost. But overall, this did trend towards a value of negative $9,470 in the ICER analysis, favoring brachytherapy as a more cost-effective approach. I know in real life, with the way that this gets billed and I'm no expert on this, but the way that this gets billed with the radiation oncologist and their involvement, that it's not as simple as just these straight numbers. And those can be other considerations in terms of implementing brachytherapy in your hospital system. And I'm continuing to learn more about that. But just based on those raw numbers, it did seem to be more cost effective. So that is really our work. In summary, the trial showed very good rates of local control, no cases of radiation necrosis, which is huge given the historical context of brachytherapy. And then our comparison analysis showed no difference in local control between standard of care and this, but it was, a small sample size and potentially favorable rates in distal recurrence and significantly lower costs. The picture on there is the gamma tile formulation of this. So I believe the ICER Ray company that sponsored this trial has since been absorbed by gamma tile. So this is what is out there on the market now for Cs-131 brachytherapy. It is FDA approved. And we're not involved with this, to be clear, but I think it's important context for this talk that they are very excited about their Rhodes trial. I went to SNO this year, and they presented it there as well as at CNS, their interim analysis of that. And they are showing improved recurrence-free survival with their gamma tile placement as opposed to standard post-op radiosurgery. And they're really running with that. We'll have to obviously see what the paper ends up showing with the full study. But for us, we were interested in potentially, that study though uses a lot of more open craniotomies, is my understanding. We were interested, and they were also interested in trying to combine their gamma tile formulation with the minimally invasive craniotomies that we do a lot of, and seeing if there's any kind of more functional quality of life or improved healing with that combination of things. But I don't know what the most kind of recent discussion on that is, but hopefully it's something we can work towards in the future. And that would also, give us the opportunity to repeat this study in a kind of different form in a context outside of the pandemic to make sure that our survival numbers actually hold up as well. I didn't put it on the slide, but I think another kind of important consideration for this would be, some centers are doing pre-op radiosurgery now, and that addresses, a lot of the potential benefits of brachytherapy are just the fact that you're doing it at the time of the surgery, and not allowing for that loss of follow-up or just delay in time that allows the other lesions to grow. So I don't know if it will happen, but a trial that's comparing brachytherapy to pre-op radiosurgery would also be very relevant and potentially a future direction for this work. But yeah, that's all I have. Thanks. Any questions?
With the survival with your study, I know it was confounded by COVID, but you had such low rates of locally and distant recurrence, with a survival average of about 5 months. So am I reasonable to conclude that the cause of death was something other than the brain metastases, like more systemic disease?
Yeah, I forget the exact number, but I think there were also a large percent of the patients that the death was, and sometimes, looking back, the study was done prospectively, but sometimes it's hard to tell, exactly why someone passed, just looking through their charts and such. But there were definitely a lot of patients that passed from just systemic disease progression, and that's, Dr. King might touch on it more, but I'm also doing a lot of just retrospective review of our minimally invasive series, just trying to look at the oncologic outcomes of our minimally invasive series overall, excluding these brachytherapy patients. And yeah, you find most of the readmissions, most of the deaths do seem to be just systemic disease progression, but then you also do find that some cases where just you don't know what happened, unfortunately. Yeah.
I think that's a really important point, that you're able to control the CNS disease well enough that that's not the patient's cause of death.
Yeah.
Any other questions? Thank you, Michele.
Thanks.